as a group, we stayed remarkably on time and loved everybody's talks. Thank you so much for really great presentations today. We do, as a result, have time, as expected, for the question and answer panel. I have been getting some questions up here on our system that were sent to us during the talks, but also the microphones are open and available for anybody who'd just like to stand up and direct a question here in the audience now to us live. If no one does that, I'll pick through the questions that have been typed in. If anyone chooses to file out as we're doing the question and answers, please quietly. Also remember to do evaluations on the way out, please. It's necessary if you want to claim CME credit for this presentation. Do we have anybody? We have, I think, first, second, and then we'll come to the...
All right, I am asking this as a pathologist. Let's say I have a biopsy, I see a Congo red amyloid. What do you want to see from the pathology report when you see the patient in the clinic for the first time?
Thank you. Wow.
Yes.
We are not worthy. That is such a beautiful question.
Well, I'll go first and then turn it over to my colleagues, but what I'd like to see is that it's been sent out for mass spec after that initial Congo red staining to make sure that I know what the type of amyloid is. It feeds into a second question which came up multiple times here, which is, this is a hematology conference. Who's treating these ATTR patients? Why are we hearing about them? And the reason we are is because, as we learned from ARC, who's done a great patient survey, amyloidosis patients are seeing multiple physicians. Half of them see 3 or 4 physicians before a diagnosis is made. And I think the more important question is not who ultimately ends up treating it, but who recognizes it first and when. And now that there are therapies that we heard about today that affect the outcome of ATTR amyloidosis, it's important for us as hematologists to identify those patients, and whether we're going to be the ones treating them or not, whether it's a cardiologist, a neurologist, we have to recognize them and make sure that they get the therapies that are needed for them.
So you basically want to see that mass spec?
We'd like to see typing. I think we'd like to see typing one way or the other. On a kidney biopsy, that can be immunofluorescence. Maybe it can be accomplished with immunohistochemistry on a specimen, but mass spec is I think, the gold standard, most reliable.
That is true, but just one comment. It depends on your pathology. So we at Columbia have an excellent pathology. So they do a digestion of the amyloid with pronase to open up the epitopes and do the light chain staining. And when they have positive light chain staining by immunohistochemistry or immunofluorescence, for instance, they show kappa, and I see kappa elevated light chains, and then I do not send the sample for mass spectrometry. But I have to say, I also saw from many patients coming from outside false negative samples. Right. So then I would be kind of on the safe side and send it for mass spectrometry. The problem what you run into is that mass spectrometry takes up to 3 to 4 weeks. And what we are praying here is the time is of the essence, at least when we send this out, because you very often have to localize an outside sample. It comes to your institution, you send it out to Mayo Clinic. So what I do when I have really, I would say, a clinically AL amyloidosis, maybe, I don't know, 45-year-old women with kappa light chains and a typical picture of renal amyloidosis, proteinuria. Then I discuss it with my patient, say, listen, I start to treat you and I send out the samples for mass spectrometry. It might be kind of 10% chance that I treat you and you have TTR amyloidosis, for instance. But I do that especially in patients who have heart involvement to really kind of save time. But it's a problem.
Thank you.
Just have a comment to follow on from Suzanne's point. When we looked at all the samples, we get all the UK samples at our center, and we have a 10% to 20% false positive and false negative rate on the Congo red itself. So the critical point for me is if there's a clinical suspicion of amyloid and the Congo red report comes back negative, please go back to the pathologist and request them to restain, particularly on a thick section, because if you do it on a thin section, you may get false negative Congo red staining and you'll miss a diagnosis of amyloid.
Jeff, everyone, outstanding talk. I'm so pleased to hear this and to be here. 2 points or 2 questions. I got here just a teeny bit late, but I didn't hear discussion about what can we do to fantastic new therapies, but how do we make the diagnosis earlier? How do we find these people? What are we doing in research to catch them before the cat is way out of the bag? That's question 1. How are we approaching that as a group, as a society?
But I think the key is really educating the people who are seeing this early, which is not the hematologist oncologists like us in the room. It's really the cardiologists that are seeing the patients with unexplained cardiomyopathy. It's the neurologists who are seeing patients with idiopathic neuropathy. I mean, these are the doctors that these patients are going to 3, 4, as Jeff said earlier, and not being diagnosed. And so I think broader education of the community that's seeing these patients, just to think about amyloidosis as a possibility and to investigate that is critical. And nephrologists also, so unexplained nephrotic syndrome is a big one.
So my second question is, darn it, no, it's escaped me, but it'll come to me in just a second, hopefully. Oh, yes. So we're very different in the United States. In Europe and in other countries, as you pointed out, all the specimens come to your center. So you have expert pathologists who are really thinking about, this is in England, who are thinking about amyloid all day long. They're really, really good at Congo red staining. Same thing in Italy, I suspect. In the United States, we have pathologists in any town, no matter any center, no matter how small it is, maybe trying to make these diagnoses. What can we do in the United States to modify this so that patients are more automatically seen at expert centers, or there are algorithms so that these biopsies are analyzed in a better manner than happens in smaller community centers, et cetera. It's really a problem in the U.S. because there is no centralization of this.
I'm not the hematologist, but it's to emphasize Ashu's point, it's really critical that the diagnosis be correct. And we see people, unfortunately, from time to time who are treated urgently but incorrectly. And the idea that they're getting chemotherapeutic agents for TTR or some other form of amyloid, or maybe don't even have amyloid, is really problematic. So if you have samples, it's not a question of how prominent your pathology department is, it's a question of how expert they are with Congo red staining.
Right.
If they do it frequently, then that's fine. If they don't, I strongly suggest that you pick one of the major centers and develop a relationship where you can get rapid review of your slides. Sending as well a couple of unstained slides so that the stain can, if necessary, be repeated at the time of the review.
Sorry, one comment. What I do with my patients who come from hematologists, that I see the patients, I make sure that I have the right diagnosis, I suggest a treatment, and I send the patients back. And maybe as a hematologist who sees, 1 or 2 amyloids, I don't know, every 5 years, my suggestion is have a relation with a hematologist at a larger center and communicate and treat the patient, but make sure that you have the right diagnosis. Sometimes I think it can be overwhelming to see, what is it? Is it, volume overload, or is the patient too dry in amyloid? So you should have also cardiologists, et cetera, et cetera. So having somebody at a larger center, that's good, and that's my recommendation.
Can I add a brief comment? I think that you, as hematologists, are in the perfect position also to make early diagnosis. I would say pre-symptomatic diagnosis, because you can expect amyloid to occur in patients with MGUS. And you have tools to diagnose them very, very early, that is biomarkers. So as you know very well, I am advocating, and Professor Merlini as well, we are advocating the screening of patients with MGUS with biomarkers if they have an abnormal kappa lambda ratio with free light chains.
think, hit the far microphone.
I'm very impressed by the progress that has been made in preclinical studies of amyloidosis. I'm speaking about AL amyloidosis now. I am perhaps less impressed by the speed of progress in the clinical treatment of the patients. I think we are making very slow progress. In fact, it's all about killing myeloma cells or plasma cells. And we need to do it very, very fast, because these patients will not be around for sequential treatments for a long time if they have severe cardiac amyloidosis. Without conducting clinical trials, I will predict that the most efficient treatment, even for frail, elderly amyloidosis patients, will be daratumumab, lenalidomide, bortezomib, and dexamethasone with low-dose dexamethasone. But the progress in the clinical trials is very slow. And I heard no mentioning of the possibility of using venetoclax for patients with translocation 11-14. That's also a very gentle way of treating frail patients. So I will encourage you to show more courage when you plan the clinical trials and move faster forward, because the patients are out there and they really need the progress very soon.
Thank you for that comment. But I have to say, we are pushing companies, but it's a rare disease, and companies think twice, 3 times before they invest in this. I always say, think about the 15% of myelomas who might have amyloidosis. It's difficult, but that's why I think Takeda started the first randomized large clinical trial. We are very grateful for this, and I think Janssen is also did an outstanding job to move on to the front line. Very brave, I have to say, with adding daratumumab to a non-existing standard of care and giving it subcutaneously. I have to say, bravo, we are very happy about this. And I hope that those large trials are encouraging, because they're accruing. It's not that it takes, sometimes it takes forever, but the newly diagnosed trial, I think, is going very well.
Thank you.
Isabel?
Yeah, hi. So I have 2 questions, one of which is, why is it predominantly men that you're seeing with, and white men, with cardiomyopathy, with ATTR amyloidosis? So that's one part. The second part is that we see patient organization that patients do better at centers of excellence that really understand and know this complex disease. What we're seeing with ATTR is a growing number of centers becoming interested and treating patients. And for patients to be treated near their home is a better quality of life. So how do we spread that expertise and ensure that patients are seen by the right physicians at the right time and given the best treatment?
Well, first of all, women are stronger than men. With regard to why there are more men than women, that's clearly a major source of investigation at the moment. And there are differences in mitochondrial DNA between gender. So there are a lot of things that are being considered. But if we can harness that, potentially we can diminish the number of men or make men stronger so they can be more women-like. And then with regard to the management of TTR, it's exceedingly important there be an explosion of physicians who are interested in treating. The more we learn about TTR, the more nuances there are. And I think it's very important that perhaps through an organization like ARC or the Amyloid Support Group, that we somehow bring up the level of understanding of the nuances, because it ends up being potentially critical in therapeutic choices. And the fact that there are drugs available now emphasizes the need to get them to patients, but that may minimize some of the considerations that the physicians are doing in choosing therapeutics. So It's a very important thing. Somehow we have to disseminate the experience.
But I think sort of to follow up on that, I think one thing that's happening naturally is that now all of a sudden we have something that we can do about these conditions. I mean, I think that before there were these patients with, let's say, idiopathic non-ischemic cardiomyopathy, where their local cardiologist said, well, maybe it's amyloid, maybe it's not, I can't do anything about it anyway, what's the difference? And now with drugs that are actually here that we can use for these conditions, my anecdotal experience is that local physicians are much more interested in this, they call a whole lot faster. And there's even people at, I think, academic institutions that have a lot more interest in this also. So I think it's naturally getting better on its own, but you're completely right, we need to do more.
I also would like.
Yes, I just had a comment about the first question that Isabel made about why men then the formation of TTR amyloid is not very clear. It's not just the misfolding, but there is some suggestion that that TTR may misfold or may be sheared by very high shear stress, such as within the myocardium, and Victoria Bullard in our lab has shown that very nicely. And therefore we see TTR in the heart, we see it in the carpal tunnels, we see it in the lower spine, all places where there is a very high stress and shear. And maybe there is something to do with the lifestyle or how the myocardium of men functions versus women, which may be a reason why we see it. We often see very sporty people, farmers, where they've been involved in heavy activity who get more TTR amyloid in the heart. And that may just be a mechanical effect rather than anything else.
I just wanted to emphasize that one thing that we can do to make treatment accessible to our patients is just collaborating with each other. We have a network in Italy, but we have also proven that we can collaborate between reference centers. And this made possible to design and complete clinical trials even without the sponsorship of companies, of course. And I think we should promote this within scientific societies such as ours and also the International Amyloidosis Society.
Yes, I'd like to go back to the topic of the diagnosis of light chain amyloidosis and ask about some details of fat pad aspirations. There's a lot of literature on that. I know there's videos on how to do it correctly, but in my community, it's often one gets scant tissue that's inadequate for a diagnosis. And if you get enough tissue to make a diagnosis of amyloidosis, there's insufficient tissue to type it. And my question is, can I reliably ask my surgeons to get a piece of subcutaneous abdominal fat, a fat pad biopsy, rather than aspirate? And what's the history behind just using a needle aspirate rather than an actual surgical biopsy of abdominal fat?
Well, I can cite my own experience, and you know, what you're asking about the amount of material that you obtain is exactly correct, right? If you have a small sample, it's less likely to be diagnostic. In fact, at the beginning of my career, I actually was doing skin punch biopsies rather than fat pad aspirates because they had a better yield for me. And in reality, all that was happening was that I wasn't getting enough material. And it was after I visited Boston and watched them do fat pad aspirates that I understood the amount of material you need. So what we get is a wad of fatty tissue about the size of a chickpea. That's what I always tell patients, and that's pretty much the amount that you really, I think, need to get it. And it's not very hard to get, except maybe in an extremely emaciated patient. Some patients do come having had a scoop, you know, obtained by a surgeon, but generally speaking, if you can get I mean, and at least in our experience, we can get an adequate sample without resorting to that.
Aspiration should be sufficient. I would not send the patient to a surgeon to do a larger biopsy. Then I would send the patient to a center to do it. Fat pad biopsies, you need some practice. You need to have somebody who knows how to do it, and exactly, we did the same, and but also a pathologist, you know, needs to be able to read kind of, you know, do the congruent staining.
If it's all done at one place by one person, they can get the expertise. If you're geographically more diversified, that's not quite as easy a solution. So
Again, I'm not one of the hematologists. I can be provocative, I think, but so if you find me lying dead outside, it's because I said the wrong thing. But if you're having trouble with aspirates, get your friendly surgeon to get a little chunk and send it.
Thank you.
I think 1, 2, and then 3. I don't know what order you stepped up, so.
So I have a question regarding when to stop anti-plasma cell-directed therapy in your patient who is clinically not doing well, but has achieved criteria for a very good partial response. How hard do we push with anti-plasma cell therapy when we have our DFLC less than 40 milligrams per liter? We've achieved our benchmarks, we pat ourselves on the back, but our patient still has an elevated troponin, they're not doing well clinically. How hard do we treat? How long do we treat?
What we usually do is to decide every time looking at the changes in the FLC, and we prolong treatment if it is tolerated as long as the FLC decrease, and if this is CR, of course it's better. Once the plateau is reached, then we ask the organ. Maybe we wait some months, and then if there is no organ response and the monoclonal light chain is still there, we change treatment to get to complete response. And now maybe, but this is not solid data. We could do the same with MRD.
I would also say that sometimes over the course of treatment, you've traded disease-related side effects to therapy-related side effects. And when you have a patient who has achieved a good hematologic response but feels lousy, taking a break from that therapy just to sort that out is often very helpful. Patients often will feel better during a break on therapy.
So I give you an example. We had a patient in the ICU waiting for a heart. Patient received chemotherapy, was in a complete remission. Cardiology came and said, what about continuing chemotherapy? Can we stop it? And I said, we can have it on hold, waiting for your heart because patient's in a CR. It's a kind of case-to-case decision. But CR is your goal. So if you have this, you might give a break if the patient's not doing well.
I'd just like to point out, because otherwise I'm really uncomfortable, that some of the people in the audience are the ones who have generated most of these data. That's Dr. Comenzo, Dr. Dispenseri, Dr. Landau, Dr. Sanchuala, Dr. Kyle. So you've got people around you. You can just ask the next person. They are a very prominent group.
Yes. We had a question over here.
Actually, I have 3 questions. The first one is regarding solid organ transplantation, especially in the context of a young patient with advanced cardiac involvement. And would you recommend it to allow therapy with high-dose melphalan? The second question is, do you see a role for PET imaging, even TC or MRI? FDG doesn't seem to be the best radio tracer, but do you see a role for PET imaging for evaluating systemic involvement in AL amyloidosis? And the third one is, would you recommend maintenance therapy in any context? Thank you.
Yes, this is very, very important, difficult questions.
I'll answer the second question because it's the easiest one to answer.
I wanted to answer the second question as well.
So PET has a role probably at baseline much more to look for evidence of myeloma-related bone disease. We find PET very useful in localized amyloidosis rather than systemic amyloidosis, where almost all the localized amyloid patients will have a degree of PET positivity, typically a low-grade uptake between 3 and 6. Patients who have higher grade uptake often have a plasmacytoma with the localized patients. So I think PET has a big role in localized AL amyloidosis where we have amyloid deposit at a single site. It has a role at baseline staging for your newly diagnosed patients with amyloidosis, much more as we would do imaging for myeloma patients. But it doesn't really have a role in monitoring these patients for their amyloid deposits per se. So the role of PET in systemic amyloidosis and localized is very different in terms of diagnosis and monitoring.
As far as the last question about maintenance therapy, I mean, in general, maintenance therapy is not a standard thing in AL amyloidosis. I'll just say in my own practice, and also because it was the subject of several questions that came up on the computer, in my own practice, in a patient with relapsed or previously treated disease who's now on an IMiD, an immunomodulatory drug, I tend to continue those because that's the way they're often used in plasma cell disorders. I also find myself extending daratumumab use, although I I don't think there's any standard about that, and a few people asked that specific question. Outside of the context of a clinical study, when you're using daratumumab, the two questions that I think several people want to know is, are you doing it in combination with other agents the way we are in multiple myeloma? And also, are you continuing it as a monthly maintenance therapy after you've started it? And I'll let you guys let us know what you do.
Well, in the phase 2 trial that we had with the French colleagues of daratumumab single agent in relapse refractory, we designed the study going up to 6 cycles. So we didn't do any maintenance, but still, for now, responses are long lasting.
Our trial the trial of 25 patients is for 2 years. So there is monthly maintenance for 2 years.
Right, but this is in clinical trial. But the general question is, and we all struggle, or at least I struggle with this, should we give maintenance in patients with amyloidosis?
Europe versus the United States, we have different design of the clinical trial.
Right, but outside of clinical trials, I think we all agree that we don't do maintenance. So patients is in CR after a transplant, so usually we would not continue with any kind of maintenance. What I do more and more is I have to say that I use MRD testing for amyloidosis. I think MRD testing for amyloidosis is much more important than for multiple myeloma. So I do a bone marrow on day 100 after transplant, and if it is positive, then I go to Heather Landau's suggestion and give them consolidation, for instance, with CyBody after transplant and check the MRD negativity again.
And with regard to orthotopic heart transplantation, could you comment from our experience or Dr. Dispenzarie? The question was, is it something that's worth considering?
Right, so, heart transplantation is definitely for advanced AL cardiomyopathy is definitely worth considering for younger patients, but it has to be isolated heart involvement without other organ dysfunction or other organ involvement. Again, each center has different criteria, and whether to do it prior to initiation of chemotherapy, whether to do it after initiation of chemotherapy, that's all a gray zone. But it can prolong survival if donor availability is there and the patients won't have a passage during waiting for the trials.
I think we in the UK, we have a policy of starting these patients on treatment to demonstrate that we can actually control the clone. Also, it takes time, as you said, to get the heart, and actually reducing light chain toxicity can make a lot of these patients better. What we've seen is that patients who actually achieve a CR, some of these patients may not need to proceed on to heart transplant because their clinical condition often stabilizes. The challenge with that is we do lose a number of patients in that process because they die before they can get to the heart. So I think the jury is still out how you actually proceed with this. But the number of patients who actually get a heart transplant tend to be fairly small. We probably do 1 or 2 every year. And even that number is kind of slowly diminishing over time.
Yes, I was just going to comment on both the heart and the kidney. We've actually gotten more patients to heart transplant more recently with the availability of particularly daratumumab, getting these patients into complete remission, but even these very advanced patients. So I think that if these patients are really super sick, they should be referred, because the whole premise of, oh, this is a clonal disease and we won't give them an organ, I still think that hearts particularly are not readily available, so we have to understand that is going to be limiting. With kidneys, however, I think that this is a really important thing to understand, that kidney, for patients who have amyloid and end up on dialysis, which is not an insignificant fraction over time, patients should be referred for kidney transplant, particularly with the availability of these directed donor programs, that they're not actually taking an organ from somebody who is waiting on a list for an organ. And I think these patients actually, their quality of life changes dramatically at the time of the kidney transplant. And these patients don't necessarily develop recurrent disease, and even if they do, now that we have available agents, we can actually treat them when they're not on dialysis.
Okay. We have time to answer questions from the 5 people that are standing at the microphones right now. We won't be able to field any more live ones, and I wouldn't dare stop the question session before Dr. Kyle gets to give ask a question. So,
I would simply, thank you very much, Jeff. I would simply like to thank the panelists. We've all been treated to an outstanding group of presentations this morning. It brought back a memory to me, however. 60 years ago, when I was on the hematology service, I saw a patient who had been admitted with a diagnosis of multiple myeloma, which was correct. But in addition to this, the patient had been seen by a dermatologist because of some peculiar skin changes. The dermatologist did not know what it was and took a biopsy of the skin, and it was reported as amyloid. And I said, what in the world is this? And I could vaguely remember back to my days of pathology in medical school, seeing this glassy hyaline-like material under the microscope. And over my 4 years of medical school, a year of rotating internship, 3.5 years of internal medicine as a fellow at the Mayo Clinic, and 2 years of Air Force duty in a 400-bed hospital, and I had never recognized, and I emphasize recognized, a case of amyloidosis before. And so I said to myself, what in the world is this? So I went to our medical index and came up with 80 cases of what we recognize today as AL amyloidosis. And the bottom line in that paper was simply that the plasma cells were abnormal. Then 5 years later, Elliot Osserman at Dr. Lynch's institution reported on 35 cases of amyloidosis related to Bence-Jones proteinuria. And then 6 years later, George Glenner recognized that the fibrils of amyloid consisted of the monoclonal light chain. And that has been a phenomenal discovery, and I can only guess at what is in store for all of us in the next decade or two as far as amyloidosis is concerned. So thank you all.
I think we have 3 more questions. Start here.
So what do you think is the role of venetoclax in the treatment of amyloidosis?
Well, it's being studied right now, venetoclax. So in multiple myeloma, it appears to be particularly active in patients with an 11-14 translocation, and that translocation is 2 to 3 times more common in AL amyloidosis. And Dr. Comenzo, who's over there, is currently leading a trial in such patients examining this drug. So I think there is a lot of excitement about testing that agent, particularly in that common subset of patients. Anyone else have any?
If somebody from AbbVie is here, we would like to do a clinical trial with venetoclax. We are all using it. I think I had patients failing daratumumab, and had a response to venetoclax with in 4 weeks. Usually they have a low plasma cell burn. You don't have to worry about tumor lysis syndrome. You don't have to admit the patient, etc., etc. So AbbVie, please listen to us.
What dose, when you're doing that off-label in
400.
amyloidosis, what dose are you using? 400? Okay. One, and then two, and then I think we'll wrap it.
This is a straightforward clinical question. What is or is there a role for anti-plasma cell therapy or radiation in recurrent or symptomatic localized light chain amyloidosis?
Yeah. So I see all of the airway and localized disease at our center. And we and the Mayo Clinic have published series on airway amyloid and low-dose radiation. And it is quite effective. You have to know that there's amyloid. You have to know that it's AL amyloid. You will not find the plasma cells on biopsy. It has to be progressive disease. It's not simply someone shows up and you say, whoa, radiation's the thing to do. You have to follow them long enough to know they have progressive disease. Surgery will help open the airway. Radiation will not, but it's very durable. So yeah, it's something to consider. If you have a case, what dose? It's 20 gray. And I'm happy to review x-rays and other imaging that you have, as well as PFTs. Yeah, bladder's interesting. So bladder's a little bit of a different animal because they get symptoms of interstitial cystitis, and that doesn't improve with radiation. It might even progress. But there's a bunch of bladder amyloid. If someone shows up on your doorstep with hematuria, someone ought to take a peek and a little bit of a biopsy because it may be amyloid.
But most of the bladder amyloid patients don't require systemic treatment because they usually got very small deposits, and simply resecting the deposit will help to manage the symptoms for many years in these patients. There's a small number who are problematic who need further intervention. The tracheobronchials are very different, and we are now doing brachytherapy for the tracheobronchial patients who need recurrent because it's not that toxic, because otherwise the broader toxicity of radiation to the chest is always a concern, particularly as often these are younger patients.
Ooh, so there's a series, we put a series out about that as well. It's, I think the senior author's from Vanderbilt now. But that's a difficult one. The radiation can effectively stop the progression, but there's a lot of issue. And even at low dose, the radiation can affect some of the homeostasis of the conjunctiva, et cetera. So it's a little bit issue.
It's critical to know that radiation is effective only in light chain amyloid.
Right. It's only, yeah.
It's
It's only AL. Yeah. Yeah. Irradiating someone who does not have AL amyloid is not a good thing.
Last question.
Thank you. I would like to follow up on what Dr. Kyle said, and I realize in over 4 decades of hematology oncology practice and teaching and clinical research that collecting data is the most important way to provide health care. Collecting data is very difficult in our United States. I come to these meetings year after year. First one I attended in Hollywood, Florida in 1972. That I find that most of the studies come from small countries, many of them in Europe, because their data is centrally collected. Therefore, they can complete a study in 1/5 or 1/10 the time that we take in the United States to do a study. It is important for lung cancer, important for colon cancer, prostate cancer, and breast cancer, but more important in less common diseases. Our pediatric oncologists do much better in collecting data and doing clinical trial. At adult, we do only 3% of patients ever go to trial. This is not the way to produce good results. Think about it, centralized data, maybe socialized medicine.
That's a good way to end this symposium. Oh, wait, Muriel Finkel. All right.
I can answer the data
collaboration with the Global Genes, their peer group, although it's not just for hereditary amyloidosis, we are starting a data bank patient registry for all types of amyloidosis. And we'll be ready to go live on that in a few months, and we'll tell you more about it. But it's for all types of amyloidosis. So,
all right.
Okay.
Okay.
Oh, and one question for Dr. Burke. Can I throw this in? You mentioned a few months ago that you were going to publish a study on bladder amyloidosis. When is that going to happen?
You didn't get the copy yet? I'm waiting for your review.
No, really, you did. You said you had something like, you said you had 80 patients or something like that.
Welcome to my life. I promise I'll send you the manuscript.
You really have a manuscript?
Yeah.
Thank you.
The fact that
thank
there's
you
so
all.
many of you left at the end of the question and answer session just attests to how much interest there is in this area within hematology now. And thank you all so much for coming to the symposium. Really appreciate it. Thank you.